Okay, so we're going to spend a few minutes talking about what type 2 diabetes is and the incidence, prevalence of it, and how that might link together in what we might do. So this is kind of the background for us to then go on and look at the dietetic aspects of it. So we're talking about a chronic, so long-term metabolic condition that is all about insulin resistance. So the cells of the body don't effectively use insulin. And sometimes there may be a reduction in the production of insulin, but often initially there are high levels of insulin as well as high levels of blood glucose. It's just that the cells aren't allowing the insulin to do their work. So about 9 out of 10 of the people who have diabetes have type 2. And it used to be considered the less serious kind, and that is a mistake because it is extremely serious if it isn't well managed. So we need to get people to take type 2 diabetes very seriously. We've got more than 4.9 million people with diabetes in the UK. And we estimate another 850,000 or so who have diabetes but actually haven't been diagnosed yet. And because of the increasing prevalence of obesity and the associated complications with that, there's probably about 13.6 million people who are at increased risk. So this isn't going to go away in the immediate future. This is something we are all going to have to be dealing with. And diabetes care at the moment is estimated to cost at least 5% of the UK healthcare budget. So very serious condition, very costly condition to manage. So to get you having some idea of the mechanisms, what's going on inside the body, I suggest you have a look at this video because it will explain it a lot better than I will, and something you can go back to and look at again and again. So that will explain all about how it actually works internally. So what we need to be aware of, and what links with the other subjects that we've been looking at over the last few weeks, is what makes somebody at risk of type 2 diabetes. And this list is a very long one, and some of these things are going to be very familiar to you. We already know that people living with obesity are at higher risk, and particularly if their weight is around their middle, so central adiposity. If people are already insulin resistant, which goes with obesity, then the chances of them developing type 2 diabetes are quite high. Family history, particularly with immediate families, so we're talking about parents or siblings, and your age, so the older you get, the more likely you are to develop type 2 diabetes. But this is very different for different ethnic minority groups. So for people of white background, 40 plus, but for people of African, Caribbean, or South Asian background, Black African, it's much, much lower. So we need to be mindful of looking at people and considering what risks they might have. If someone already has high blood pressure or hypertension, then they may be at increased risk. If they've got cardiovascular disease, or if we have a woman with polycystic ovary syndrome, or someone who's had gestational diabetes. We have high intake of sugar sweetened beverages. So if you're taking in high carbohydrate, high amounts of sweet food, then your body is having to work harder because of all of that carbohydrate that needs to be processed. So if that happens over a long period of time, that is tiring out the pancreas. It's making it have to work much harder. Some mental health conditions, such as depression, schizophrenia, bipolar disorder, will increase that risk as well. People who are sedentary, high alcohol consumption, and poor sleep. So we've talked about that linking with obesity, but that can also add to the risk of someone developing type 2 diabetes. So there's a lot of people will have a number of these risk factors, hence the estimations of what the problem will be going forward. So signs and symptoms, what do we need to look out for? So we're talking about people who are urinating more, bigger volumes and more frequently, particularly during the night. So nocturia is in the night. People who are very thirsty. So the body is trying to dilute the sugar by making people wee out more, and therefore they become thirsty. People become tired and because they are not getting the glucose going into the cells to do their activities of daily living. Sometimes people might have lost weight, but not so much with type 2. That would be much more a type 1 symptom. But people may also have blurred vision, thrush or genital itching is more likely to be common because of the sugar that is in urine. So that will make it much more likely you're going to get infections. And slow wound healing. If blood sugars are high, that makes for slow wound healing. Not everybody's going to have every symptom, and it's a slow developing thing, so sometimes people don't really notice. And they reckon that a lot of people may have it for 10 years or so without realizing. And because it's not as acute, it can be missed quite easily. So lots of signs and symptoms to look out for, but they may not always be that visible. So how do we diagnose diabetes? So we have World Health Organization diagnostic criteria. We have NICE guidance for UK, England and Wales, and that was updated in June last year. But some of these figures haven't changed. So there's a whole load of different criteria that have different usage. So depending on the scenario. So with the WHO, they're looking at what's feasible in a variety of countries, of course, across the world. So all of these things down the left-hand side here, random plasma glucose and fasting plasma glucose, you only do those if someone's got symptoms. In some places they might do oral glucose tolerance tests. So you take 75 grams of glucose, usually in the form of something like Lucozade, and you monitor blood sugar after 2 hours. So that should be below 11.1 in order to be healthy, but above 11.1 would suggest that the person has diabetes. So that we used to do in the UK, but now we don't. So what we tend to do is to do glycated hemoglobin. So what this is, HbA1c, this is a measure. It measures the cells to which glucose has stuck to over a period of time. So it's really an indication of blood sugar control over the last 3 months or so. The only difficulty with that is if someone actually eats a very healthy diet and exercises and are maintaining their HbA1c, it doesn't necessarily mean that they haven't got a problem. It could be that so if they were to go out and have a big slap-up dinner with lots of alcohol and lots of extra things, they may well get raised blood sugars. So this is the value that we use. We don't routinely do the other things anymore unless there are symptoms, but it can mask things. But it does give you an idea of how the control has been over the last 3 months. The reason it doesn't make a lot of sense with pregnancy is because gestational diabetes won't have been around for the last 3 months. It's something that will have developed during pregnancy. It isn't something that is there at the start of pregnancy. That would be type 2 diabetes or type 1 diabetes. It wouldn't be gestational diabetes. So these are the kind of things that we're looking for, and GPs will routinely do the HbA1c for someone who's perhaps at high risk or someone who's had some symptoms. But they might just do a finger prick test for someone who's had symptoms. So most often we're looking at HbA1c. So this is a little small, I just give you an idea of it, but it's looking at what the normal range is. So normal is below 42 millimoles per mole, or below 6%. So it's up to numbers, either the percentage or millimoles per mole. Someone who has pre-diabetes has a range between 42 and 47 millimoles per mole, and 48 millimoles per mole or over is diabetes. So most often we're using millimoles per mole as the key measurement. And this is the thing that we would be aiming to help a patient improve, because there is evidence that a 1% fall in HbA1c, which is maintained over a while, decreases the risk of the long-term complications by 25%. So that's massive for changing things and making things more healthy in the long term for our patients. So when is HbA1c not appropriate? Children and young people, it used to be that if it was a child, it was only type 1. That's not necessarily the case anymore. I think the youngest person diagnosed with type 2 is aged 4, which is really quite scary. That never used to happen. If at any point anyone is suspected of having type 1 diabetes, so they may have a very high blood sugar level, you've got to treat that urgently. I think this one's interesting. If people have had symptoms but they're quite recent and they haven't actually been going on very long, they might not necessarily be due to diabetes. So therefore, if it's been going on for less than 2 months, an HbA1c isn't going to give an accurate measure. Somebody who's acutely ill, of course, or someone who's taking a medication that might cause diabetes-like symptoms, such as steroids or antipsychotics. And if somebody has other damage to their pancreas, so that would include pancreatic cancer, pancreatic damage, or surgery, that's not going to make any sense. And there are some genetic factors which mean HbA1c doesn't have the same impact. It doesn't function in the same way. So there might be those occasionally as well. And in relation to gestational diabetes, what we need to think about is different numbers. So this is the diabetes that comes on purely in pregnancy, and those levels are slightly different. So they might do a fasting plasma glucose, and this will often be done during pregnancy, but they will also be often doing urinary measurements to see if glucose is in the urine, and then following that up perhaps with a blood sugar blood glucose measurement. And sometimes those have been done in the oral glucose tolerance test, might actually be done as well in those circumstances, but that's a different type of situation. So what we've got there is just a brief overview. The Diabetes UK website is a really good source of information for understanding what is happening as far as diagnostic criteria is concerned, and the NICE guidance.